Welcome to Inflection Point. Our webinar will begin shortly. This session is being recorded and we will send a link out to everyone. Also, there will be a Q&A session after the presentation. You can enter questions in the question box at any time during the webinar. Thank you. Welcome to Inflection Point. Our webinar will begin shortly. This session is being recorded and we will send a link out to everyone. Also, there will be a Q&A session after the presentation. You can enter questions in the question box at any time during the webinar. Thank you.
Hello, and thank you for joining Inflection Point, hosted by the Go Red for Women Venture Fund. Inflection Point explores a new frontier where science, investment, and innovation intersect to elevate the health for women. Today, we are exploring autoimmune disease, complex, high-cost conditions with fragmented care journeys. 50 million Americans live with autoimmune disease, 80% of which are women. Autoimmune disease spans more than 100 conditions, from lupus and rheumatoid arthritis to multiple sclerosis and Crohn's, and they all increase the risk of heart disease and stroke. To discuss the complexity and to illuminate the massive market opportunity, I am joined by two leading clinical researchers, Dr. Karen Kostenbader and Dr. Brittany Weber. Dr. Kostenbader is professor of medicine at Harvard Medical School. She holds the Michael E. Weinblatt, MD, Endowed Chair in Rheumatology in the Division of Rheumatology, Inflammation, and Immunity at Brigham and Women's Hospital, where she serves as the director of the lupus program and chief of the section of clinical sciences. Her research investigates the epidemiology and pathogenesis of systemic lupus erythematosus and rheumatoid arthritis in particular. Dr. Brittany Weber is the director of the cardiorheumatology and cardiodermatology program at UT Southwestern. She also serves as an assistant professor at UT Southwestern's Department of Internal Medicine and is a member of its division of cardiology. A cardioimmunologist, clinical investigator, and imaging specialist, Dr. Weber's research investigates advanced imaging, molecular biology, and clinical trials and population health to understand how systemic inflammation and immune deregulation drive cardiovascular disease. I want to thank you both for joining us today. And for our audience, you can enter your questions in the Q&A and we will get to them at the latter part of the program. So Dr. Kostenbader, I'd like to start with you. We're going to show here a video of this journey and this care odyssey that many immune patients face, where we have a repetitive visits with specialists, primary care doctors, medical trial and error looking for therapies. And we've kind of outlined this for the audience to understand just how complex and challenging this journey is for patients. To better understand that the autoimmune conditions, which encompass, again, as we said, more than 100 diseases, Dr. Constibator, can you help outline the breadth of what we're talking about here, both similarities and differences across these vast conditions?
Yes, thank you. I love that diagram. I think it does put, a visual image to the problem, one of the problems that we have in autoimmune diseases, because autoimmune diseases are so many different diseases, as you said, over 100 different diseases, and they have some common points and similarities, but they're also very different. And one of the things they have in common is that they often are not clear at diagnosis. They can start with vague symptoms. So, they can be neurologic symptoms. They could be skin disease. There are so many different ways that these diseases, including multiple sclerosis or autoimmune liver disease, or different skin conditions or heart conditions, can present, that often they're relatively rare and providers don't recognize them or think that they might be infections, which they could be, or they might be malignancies, which they could be. So there's just so many things for providers to be aware of that they can go unrecognized for a long time. The population with autoimmune diseases is mainly women, across all more than 100 autoimmune conditions. Really, it's predominantly women, and that can vary from over 90% of patients with lupus or Sjogren's syndrome or scleroderma are women. And then, more closer to 2/3 of patients with rheumatoid arthritis are women, but it's usually women. And it could be young women. So young women presenting with strange symptoms in general, maybe they'll go away. Maybe the fatigue is just stress at work. Maybe, the low-grade fevers is a viral infection. So it's hard to pin these down. And it can go a long time without being recognized, without being the right test being sent and the right specialist getting involved. And then even in your diagram, after a diagnosis is made, sometimes there's still uncertainty for a long time, even by specialists, about what's going on. It can take a while for these diseases to kind of declare themselves. So people with a positive anti-nuclear antibody and symptoms of fatigue and joint pain could be developing any number of different autoimmune diseases. And it's hard for us to know which one it might be. And then even after that, if we figure out that it's lupus or it's rheumatoid arthritis or it's scleroderma, finding the best treatment is very hard. And we're not really there yet with personalized care. These are very heterogeneous conditions, even within a diagnosis. There are many different phenotypes of disease. And you mentioned that cardiovascular disease is unfortunately increased in most of these conditions due to the inflammation, and Dr. Weber will speak more to that, and all the cytokines that are circulating. But the more we delay in really tamping those down, and people are having ongoing symptoms of systemic inflammation, damage is being done. Atherosclerosis, among other things, is progressing. And then we get into trouble early and late with atherosclerosis and heart disease in autoimmune diseases. So that diagram does kind of encapsulate how the ambiguous symptoms can be dismissed or misdiagnosed. The cycle can go on for a long time. And then even if someone presents with very flagrant disease, we don't know from experience, which medication necessarily to reach for first and which will be the most efficacious. So there's some trial and error there as well.
Yeah, which sets the tone for a lot of opportunity for innovation. So, Dr. Weber, let's pull on that thread a little bit and talk about how autoimmune disease impacts a cardio risk profile for patients.
Yeah, thank you so much, and thank you, Dr. Constibator. I have a real mispleasure to have had the opportunity to work with her for now a number of years, and I'm so glad we're here discussing this issue today because this is something I feel deeply passionate about, and I really do love this diagram because it really shows you the complexity of what we're dealing with. And in terms of something I think about every day is really the cardiovascular risk of these patients. And so, as Dr. Conspiter mentioned, we know that the majority of these conditions are associated with an increased cardiovascular risk. Some conditions have higher cardiac risk than others, but the kind of notion of systemic autoimmunity is true. And when I talk to people about this, I like to really point out what I believe to actually be an important paper in the field a couple years ago, by Conrad et al. In the Lancet, one of the top journals that looked at 22 million people in the United Kingdom. And what they did is they identified people with autoimmune disease, and they looked at many different autoimmune diseases. They didn't look at just lupus, rheumatoid arthritis, even though these are very important conditions we think about, and of course I study, but it looked at a host of autoimmunity, according organ specific, even such as common dermatologic single organ specific autoimmunity, such as vitiligo. That's not common, but a skin specific, as well as the systemic autoimmune disorders, such as the mixed connective tissue disease and lupus and systemic sclerosis. And what they demonstrated in that study was that all these different autoimmune conditions were associated with excess cardiac risk when you compare them to the age and gender matched population in the UK without those conditions. Furthermore, what I also thought was a really nice point of this paper is they demonstrated that the number of autoimmune diseases may matter. And Dr. Conspater alluded to this, is not our patients may have actually more than one diagnosis, and the people that had more than one or two or even three autoimmune diseases, that excess risk kind of just went like this. So this really shows us the importance of that autoimmunity in driving cardiovascular risk. We know this risk is complex, and it differs between each of the different autoimmune diseases. We also know that there is a common thread when we talk about cardiovascular risk. We think about a lot of atherosclerosis. It's not just atherosclerosis, as many of these patients can present to a clinic like mine with heart failure, with valvular disease, with chest pain that's actually inflammation around their pericardium, such as pericarditis. But what we talk a lot about and worry and we want to screen for is this enhanced atherosclerosis risk as well, between the common thread of these conditions. And we've had, with the role of imaging, we've had increasing data to show that people with autoimmunity have more plaque and they have higher risk plaque. So you can see that this is a very complex problem, and this delayed diagnosis only further compounds the problem that we're dealing with.
And how do you advise both, I would say, patients and then those thinking about this intersection of multi-specialty, interdisciplinary needs for these patients? I'd love for either of you to just speak, how ideally, if you could redesign the system among these two kind of specialty, pockets. How do you help patients both be educated, but also then, advocate for themselves for optimal outcomes when they believe they have an autoimmune condition?
I can try to take that. And that's a hard question, redesigning the system. In my dreams, I think that every autoimmune center of excellence for whatever disease would have a Dr. Weber associated. We need cardiologists that also these diseases really are multidisciplinary. So in our lupus program, we used to have Dr. Weber, but cardiologists are involved. We have neurologists involved, psychiatrists involved, OBGYNs. It really takes a lot of different people because these autoimmune diseases affect many different organ systems. And we need a cardiologist specialist or preventive cardiologist to think about the risk factors for atherosclerosis and other heart diseases in these people with systemic inflammation, and about their risk factors, about their traditional risk factors, about being very aggressive in lowering their cholesterol and their blood pressure and getting them to stop smoking and things like that. But also, what other medications should we use to try to tamp down on the inflammation, and to do this together? I think that is one of the challenges of the system, that it doesn't always allow access to other specialties. It doesn't always allow access to any specialists. Our healthcare is a little fragmented across the country. We have geographic and regional access problems. There are not as many rheumatologists as there should be in the country. Definitely, there are whole states that don't have rheumatologists. And then having this really good communication between a rheumatologist and cardiologist, and an ability to talk to the patients about that too, and about the ability to talk to patients about why it's important, because they're coming because of their hair loss or their joint pain or some other autoimmune manifestation. And we have to convince them that actually they're also at risk for heart disease, whether or not they have chest pain or symptoms. And they need to, talk to and think about their cardiac risk. And there just a lot of information to convey to patients and to communicate with patients. So the more people that are involved in kind of supporting patients and fostering that communication, the better. And I'll let Dr. Weber.
Yeah, no, I that was so well said, and I couldn't agree more. I mean, my dream is obviously that we can continue to grow the multidisciplinary nature in the field of cardiorheumatology. I feel deeply passionate about this, and that there is a need for cardiologists who are specialized in this. The complexity is so vast, as you've already alluded to, and we can't expect every cardiologist who are or rheumatologists to keep up on, the rapid pace of each of these two specialties. Rheumatology is going like this, cardiology is doing the same thing. And patients really appreciate having a specialist that not only understands their autoimmunity, can, hear their journey and their pathway to get to where they're at, but then can actually understand the differences between the biologics, the nuances between what may have more or less beneficial risk. We need more data there, but these are the things that at least a specialist in this community can help bridge along with a rheumatologist. I always, rheumatologists are amazing, and offer many PCPs. Their rheumatologist is their PCP, and the PCP, and whether or not the rheumatologist wants to have that condition. And so you see that they have so many things they're trying to manage in a short clinical visit. And so I would never expect a rheumatologist to be covering everything there is to do in terms of the evaluation and longitudinal monitoring and management and medications that are often required for many of these patients. And so part of the thing about redesigning that system is actually enabling more access and more multidisciplinary care, because as she already alluded to, right now our care is so fragmented, and it does affect our patients, and it further drives their increased cardiac risk.
And both of you touched on the fact that there are biologics and other therapies out there, and it's sort of, there's a system of sort of step therapy and how these patients have to go through kind of the trial and error. I'd love for you, starting with Dr. Constibator, talk about this step therapy, the role of biologics. We know they're expensive, but they are in many cases effective. But help our audience understand the factors, and as a rheumatologist, how you think about these and the utilization for your patients.
That's a good question too. And as Dr. Weber just said, rheumatology, the field is really exploding, going straight up with all kinds of new medications on the scene. And lots of trials going on, new biologics, new mechanisms being identified. So it's a really exciting time. Not all of these will make it through the gauntlet and get FDA approval and become new therapies for patients, but there's definitely a lot of excitement. And even in my disease, lupus, there were no biologics before 2011. In fact, there hadn't been a new medication approved for over 60 years in lupus until 2011. So, and then since then, there's just a lot of interest. There are new biologics and more on the horizon. But we still don't have, and this is true in other diseases too. Rheumatoid arthritis now has a bunch, very effective. Psoriatic arthritis and psoriasis have a bunch. We don't know a lot of things about them though, because they're new. So they do seem to be effective in the different diseases, targeting different mechanisms, all of which do tamp down the inflammation and affect the immune system, sometimes in similar, sometimes in different ways, affecting cytokines, monoclonal antibodies or receptor blockers, sometimes taking out the adaptive immune system, the B cells, generating autoantibodies. And we don't have long-term experience with a lot of them. And we do think that by decreasing the systemic inflammation, getting people feeling better, getting their joint pain to be resolved, getting them, out of the cycle of fatigue and cognitive fog and all of this, that their heart disease will also improve and their cardiovascular risk will improve. And there are some data from older studies and trials of things like methotrexate even does decrease the risk of cardiovascular disease in patients with rheumatoid arthritis if their disease is well controlled. And there are newer data with belimumab and other biologics, but we still don't know which ones are the most effective, and we don't have personalized care yet. So you alluded to step therapy, and that's really been the paradigm for many, many years in rheumatology and other disease areas. That you diagnose someone, well, you try this first. And it used to be that you tried an NSAID such as ibuprofen for a while. If they failed that, or you put them on steroids. And we know steroids have a lot of side effects. But you start that. If they failed that, then you'd step up to the next strongest medication. You put them on a disease-modifying medication such as methotrexate. And after a while, if they failed that, then you would step up to something else more expensive for sure. But now, in terms of this cycle that we've seen, now you've let years go by where the damage is being done, the patient is feeling horrible, and you really haven't attacked the disease and all those other risk factors for heart disease and other things that are going on because of the systemic inflammation. So insurance companies still would like us to do step therapy, try the cheap things first, see if they respond. But we know, especially for patients who really have the most serious organ involvement kind of disease, that they're not going to respond. We don't yet have personalized therapy. We don't have the right biomarkers to say, oh, and this person has an interferon gene signature that's XYZ, so they need this medication, versus this patient has more of a B cell signature, or this patient has more of these autoantibodies, so they should get this medication. We're not there yet. We need more head-to-head trials. We need more biomarker development, but we also need the paradigm just to shift to recognize that patients have a severe disease earlier and to start really effective medications much earlier to prevent damage. And the damage, some of the irreversible damage of these diseases includes heart disease.
Yeah, I couldn't agree more. And this is such a challenging issue. And I will say, in terms of areas of opportunity for the future, what we certainly don't know because of all the access issues is also which biologic would be more efficacious in terms of reducing that cardiac risk and which cardiac risk mechanism it is, right? I mean, we can't say that pericarditis is similar to heart failure, to atherosclerosis in terms of which pathways may be more beneficial within each of these diseases. So one can actually imagine the incredible complexity. What I think we can appreciate is that not all biologics are created equal, although we do believe the general notion that reducing inflammation reduces somebody's cardiac risk. We also know that some of these biologics have different risk associated them, including drugs that may drive up your blood pressure. We have a lot of data that long-standing steroids also worsens glycemia, hypertension, obesity. So chronic steroids is something we're trying to mitigate in general in the field of rheumatology. And even within the different, biologics a patient may come with, perhaps, I see a patient in clinic with severe atherosclerosis, and if I was wanting to kind of target a specific biologic that I thought would be more beneficial, we can't do that, right? And that's going to create it to be able to understand those answers. We have to do research on those, and unfortunately, just the way these process and approval works for many of these conditions, those are not really studyable questions right now without funding to really be able to do large scale trials to understand that.
Sounds like there's both opportunity for biomarker development to help drive this personalization, as well as large studies to really look at the interconnected effects of these therapies and to help prescribers decide which is best for an individual patient. So super, super interesting areas. Dr. Weber, I want to shift a little bit now to talk about guidelines for care, because I think that's one of the things in autoimmune that is perhaps different than cardiology, where you also practice, right? Where, I would say not extensively, but largely in cardiovascular care, right? There are guidelines. There are, diagnostic algorithms and treatment pathways and things. Autoimmune is often not sharing that structured framework, and part due to the lack of information we just discussed. But can you talk about that? You have a unique perspective of sitting in both worlds about the the differences, and then maybe even follow that with sort of what do you think would it take for autoimmune to have more of those? Or maybe Dr. Constipator could talk to that as well. Like, how do we get there for autoimmune?
Well, I mean, I can certainly talk about absolutely guidelines in terms of cardiac risk, because you're absolutely right. We have a lot of guidelines in cardiology. And in fact, we actually just had the most recent prevention guidelines published just a few weeks ago, which were, to me, quite exciting because it really enforced, lifetime cardiac risk, more specific data on threshold goals. We updated risk scores. We updated imaging in there. But what we know, though, is that, a patient with an autoimmune disease, we cannot, these calculators that we use in cardiology to calculate someone's estimated cardiac risk, they don't take in the fact that these patients have had longstanding lupus. And in fact, this is work I've done over the last couple of years with Dr. Constipator and Dr. May Choi, who's a brilliant rheumatologist up at University of Calgary, where we actually did a study where we were trying to understand what additional features with lupus help predict cardiac risk. And we developed a risk score that one has a calculator, and a clinician can go online and use it today that kind of estimates the enhanced cardiac risk by adding in lupus specific features. But the reality is that this is not what we're not there in clinical practice. These require large, validation in other centers. And oftentimes at the end of the day, these patients that are coming to us, they're also coming with lack of awareness. And then often, even if a cardiologist may know that patient should be on a statin because say that they've got the risk factors, then there's the complex of, of perhaps there's intolerance or perhaps there's nuances with those medications. And so what we truly need, I do believe, is that we do have to get to an area where we have better guidelines, because until we have better guidance, we're not going to really change this at a large scale in terms of getting people with autoimmune disease treated or recognized for their cardiac risk early. I will say that one area that I've spent a lot of time in, and that I do believe is really important for innovation in the future, is the role of imaging and in autoimmunity. Is that we know that these patients, they're so heterogeneous, and not everyone is equal, and that I do believe that screening with imaging is a way we can detect disease earlier that can then allow personalized treatments.
Yeah, that's great. I think, yeah,
Great.
sorry, I was going to pick up on the same question. But okay. In terms of guidelines, it is true that rheumatology, we're getting there with the guidelines, but we do not have as many guidelines and treatment algorithms as they do in cardiology, for example. And a lot of that is that our diseases are a little bit more rare, so we don't have as much experience, and we don't have the data. We're getting there with the guidelines. New guidelines for the treatment of lupus, for example, and rheumatoid arthritis and systemic sclerosis have come out from the American College of Rheumatology. And they do address cardiovascular disease prevention as a global addressing of that field, acknowledging that in the new paradigm, we really need to get people off of steroids. Back in the 1990s, early 2000s, we used steroids, prednisone and Solumedrol, way too liberally for way too long. They work, they're very effective, and they cause a lot of side effects, including, as Dr. Weber said, they drop up blood pressure and lipids and weight gain, and really cause the metabolic syndrome, and maybe lead to the thrombosis as well that complicates atherosclerosis. So we really have to get people tapered down off of their high-dose steroids as soon as possible. But to do that, we do need to use biologics, and that's where we don't know which one to use and which patient yet, and we don't really have personalized medicine. I think, as Dr. Weber said, that we have been thinking about how to personalize the risk score for a person for cardiovascular risk in lupus, in RA, and other diseases, based on their traditional risk factors, but also their disease-related risk factors, because every patient is different, and how much inflammation they have, and whether they have kidney disease, or whether they have low complements, whether they have certain autoantibodies, does influence their risk. And the risks are very, very high. For lupus, for example, in young women, we really do not see cardiovascular disease in, 15 to 25-year-old women aren't coming into the emergency room with MIs without lupus. With lupus, they do, and the risk is much higher. In that age group, it's been said to be up to 50 times higher, so very high. Overall, it's probably, about 9 times higher for women. So much higher. And then it varies for rheumatoid arthritis, maybe 2 to 3 times higher, but much, much higher than the general population. But which medication to grab to beyond the statins for reducing their LDLs, and the blood pressure control and ACE inhibitors and ARBs and beta blockers, which we do. What else to do we don't know. And how often do we do screening? And we're also changing. I think we are looking to the cardiovascular disease guidelines about screening, but those are general population guidelines. Yeah. So it's hard for us to know. We know our patients are at much higher risk.
Right.
So, getting a young woman to walk on a treadmill, maybe that's not the right screening test.
Right.
But then do we send them for, a PET scan? Do we send them for an MRI, a coronary artery calcium score? And how often? If it's normal today, what about in 3 years after they've been on more steroids for another big flare? So there's just so much we don't know. We need more data. We need more studies. We need more prospective studies to inform guideline development. I think it's a field that's ripe for development of these guidelines, and hopefully that will improve care and outcomes.
Absolutely. Absolutely. We do have our first question from the audience, so I want to be responsive and perhaps start with Dr. Weber on this one. Can you speak to whether psoriasis predisposes a person to heart issues and why, and kind of the interplay there with psoriasis in particular?
Thank you for whoever asked this question. I love this question because the answer is yes. And sometimes it's not an autoimmune disease that we talk about enough when we're just saying all of autoimmunity. One, it is one of the most common immune-mediated as inflammatory conditions by prevalence, and it is clearly associated with excess risk. When we talk often about the female predominance of autoimmunity, that is true for the majority of diseases. Psoriasis is one that you actually see a little bit more equal. So you do see more males present with psoriasis, but it has been actually known now for decades, actually, really, that patients with psoriasis have enhanced cardiac risk. And we have, I would say that a lot of evidence now that really points to that. We also know in psoriasis, which is also similar, to the, disease like rheumatoid arthritis and lupus, that the severity of the disease matters. There's a very well-known paper that was published in JAMA almost 20 years ago that also highlighted the point that Dr. Conservator just made of the young. And it basically looked at patients across the lifespan with psoriasis with mild skin disease or severe skin disease. Right. And so when we talk about biomarkers, this is really a dermatologist judging the severity of their skin disease. And the people that had severe psoriasis, including it was most pronounced in like the 20-year-old range, because many times these people were presented as adolescents, had a much higher relative risk of having a heart attack compared to people who just had mild skin disease. So this is literally just taking psoriasis and comparing mild to severe. And I've been researching psoriasis for many years. I work with Dr. Marola now down here at UT Southwestern, and we've actually just started. There's a couple cardiorheumatology clinics, not enough, but there's a couple of them. But we've really started what is one of the first launching the first cardiodermatology programs. And so I spent a lot of my time actually, going to meetings, speaking to dermatologists about this enhanced risk, because this is often when we talk about awareness, something that it's not on somebody's radar to be screening and talking to your patients about that enhanced risk. And of course, similar to all these other diseases, the field of psoriasis and the therapies for psoriasis are exploding. But again, there's a lot of different pathways one can target, and whether one is more beneficial than others in terms of reducing this cardiac risk is still unknown questions in the field.
Great. I want to follow up on that maybe a little bit too, is, we've talked a bit about some of the challenges clinically, but let's back up maybe a little bit and talk about severity of disease across. So not only do you have breadth of conditions, right? You have these continuums of severity of these conditions, which exacerbates probably a lot of what we've talked about today. Flare-ups, frequency of that. I mean, let's talk a little bit, maybe starting with Dr. Conservator, about how you think about getting that data from patients, right? Patient-reported outcomes are a big, how they're feeling, those are softer, but managing the condition not everything is a test that gives you a score, right? There is a lot of inputs for clinical decision making here. Can you talk a little bit about how you do that in practice and where you see maybe some opportunities for better data capture or standardization, really trying to help move the field forward?
Yeah, thanks for that question too. Yeah, I think most of our autoimmune diseases do not come and stay. Some do. I mean, some skin conditions, but a lot have fits and starts and periods of flares and then quiescence. And our job as rheumatologists, especially for the diseases we treat, and there are autoimmune diseases treated by many different types of specialists, honestly. But it is to keep the disease in a low disease activity state or in remission. So to drive the disease activity down and to keep it there. But people continue to have periods of flares, trying to sort out whether they're really having a flare of the disease activity versus they're just having something else and they're like insomnia and they feel horrible, or depression and they feel horrible. We do have some biomarkers and we don't want to overtreat people. So we do collect patient-reported outcomes. We do watch for patient-reported outcomes, fatigue scores and pain scores and overall health assessment scores over time. I think that in trials, they're very good about collecting these data now. There's often a discordance between what the doctor thinks is going on in the disease activity and what the patient thinks, especially when the patient says, I think my disease is active, and then the doctor says, well, on exam, I didn't see anything, and all the labs look fine. So we still don't have the best biomarkers, and then we always we have this continual problem of trying to sort out whether the disease is active in a patient who says it's active or they're not feeling well, but their labs look fine, and because we don't want to overtreat. I think in terms of opportunities for the future, everybody's going towards apps, and we do have different companies that are designing apps and platforms for patients to track their disease activity online or on their phone over time, and then track them for themselves, and track it for their doctors, track it for trials, many different things. There is some app fatigue as well, but there are lupus apps, for example, and rheumatoid arthritis apps, and maybe psoriasis apps, maybe psoriatic arthritis apps, where on a daily or weekly basis, patients, just log in and ask a few questions about their level of pain, their level of fatigue, their rash, their joint pain. And then you can see a pattern over time, and they can bring that to their physicians. They can think about, well, did I forget my medications? Was there something else setting me off? Or if it's, really they're having a big flare when they come in, then it's a time to intensify medication. So I think that, we need to get better at, collecting all these data and using them in real time without burdening either the patient or the physician, but using them to increase communication and really follow people more closely.
Great. Dr. Weber, anything to add to that question?
Yeah, other than I agree. I mean, this is really where innovation can happen. We have to be creative, right? As we think to solutions to the problem. And I love the kind of the what you were talking about with like disease app tracking. And in terms of the cardiovascular risk, we have to think of more innovative solutions to be tracking cardiovascular health, and targeting blood pressure management, weight management, diet and lifestyle interventions. And so I think that this is an area of the future, and one that I hope that we can continue to work forward in the future.
I have another audience question, so I'm
Yeah.
going to throw this, starting with Dr. Weber. For someone who's diagnosed with lupus as a child, but has been in remission for many years, how does a patient think about managing their lupus? When they're when to see a specialist, how to think about heart disease? Like, talk a bit about someone who feels they're in that sort of steady state, but wants to be preventative and proactive about their health. What guidance do either of you have for them?
Yeah, it's a great question, and I will say that when I think about autoimmunity, it's important that I'm seeing these patients, not just when they're active and flaring, right, in terms of their autoimmune disease, but even if a patient is being treated and they are, quote, stable, these patients still have excess risk. So I think that we want to make sure that the patient with these conditions knows that although we all believe, both rheumatology and cardiology and specialists, that controlling the disease is what our ultimate goal is, but that does not mean that their cardiac risk is not zero, right? And so it is the complex interplay by both the traditional cardiovascular risk factors as well as the immune dysregulation that defines these diseases that we believe is driving that risk. So a patient that may be stable on their in terms of their lupus over a number of years, I would still recommend to be undergoing all the general prevention screening, and this is kind of what we alluded to earlier. And then in terms of the things that I always think are important as a cardiologist is that we have to treat what we can treat, right? We've Dr. Constipator and I've talked about a lot of things that are unknowns, right? And personalized medicine and tailored therapies, these are all things we hope we can get to. But I can tell you the reality of the fact is that I do research in this space. And if you just look, we know that many of our patients with these conditions, when we look at our own healthcare systems, they are undertreated for the things that they can treat. So just because a patient may have stable lupus does not mean that their blood pressure does not need to be at that goal, right? It does not mean that I want their weight at a healthy weight. And so we have to make sure that what we can treat today in 2026, we're treating very aggressively in our patients with these conditions, just similar like that we should be doing for the general cardiovascular patient.
Dr. Constipator, further thoughts?
Yeah, I couldn't agree more. I mean, we see a lot of patients who've had lupus for many, many years. And I think that when their disease is stable in that low disease activity state or remission, that's a great time to breathe a little bit and think about what else. We should be talking about your cardiovascular risk because you've been on steroids in the past, because you've had kidney disease in the past. These are your traditional risk factors. These are your lupus-related risk factors. Let's make sure you see the preventive cardiologist. Let's see the nutritionist. Let's get you into an exercise program. Let's work harder on that blood pressure or the cholesterol or the smoking cessation and all of these things. That sometimes when someone's really sick, unfortunately, we say, okay, we'll address that next visit, but right now we have to do this. But it's nice to have a little bit of time to have that collaborative, multidisciplinary care. So to make those appointments, to get in to see those appointments, and to think about other things in preventive health.
Right. Well, you're both, phenomenal clinical researchers. One question from the audience here is, what do you think is next in terms of biomarker discovery for patient stratification? So much to our earlier conversation around this personalization as it relates to research in the scientific community. Like, where do you see the next frontier in either of your areas? So, Dr. Constipator, I'll start with you, and then we'll ask Dr. Weber.
Okay, I have to put my nickel down somewhere, huh? There's so much research going on that it's hard to know what is going to be the most fruitful in the near future. I think that companies actually are thinking when they're developing medications and testing them in clinical trials about companion biomarkers and diagnostics. So if they're blocking interferon, they're thinking, do we need to have an interferon assay that goes along with this test? So it may not be a one size fits all, but there are many, many kind of multi-omics studies going on, looking at proteomics for potential biomarkers of the proteins, looking at metabolomics for potential biomarkers among the metabolites, looking at definitely gene single cell and bulk RNA sequencing for gene expression profiles. Looking at B and T. Okay, I'm not putting my nickel down, but there's so much excitement. We've been working on cellular signatures, of which lymphocyte populations have been upregulated, and I think that gives us a forecast of developing lupus and developing severity of lupus or maybe response to therapy. We are conducting a trial now with people newly starting 3 different medications for lupus, and we're going to be looking at multiple types of biomarkers for response to therapy. So getting their blood and their information at baseline. They start different biologics and medications, and then we follow them for cell signaling as well as cellular profiles, single cell RNA-seq some of the proteomics, so I think there will be new biomarkers, and they will tell us not only which patients should get which medication, but which medication they're more likely to respond to, which is, there is the mechanism, but then also maybe they won't have a response for another reason. Yeah, so Dr. Weber has
Yeah.
thoughts as well.
No, I love it. I love it. And this is always tough putting your nickel down. But I couldn't agree more with Dr. Conspater, because I think all these are really important. And if I have to add one additional thing in terms of what I believe is really important for the future, and obviously something I think a lot about, is actually the role of cardiovascular imaging when we think of the areas of innovation and advancement. We're making progress, right? Even in our new prevention guidelines, we see an increasing emphasis on calcium scoring, but we have even further innovative tools to diagnose disease. And I helped co-chair an NIH workshop last fall, where we really got together and talked about the focus of prevention, like what is going to be a screening modality by which patients by 2040 will be able to have to be able to screen for atherosclerosis. And I think areas of innovation in terms of imaging technologies is both include for autoimmune patients is coronary CT. This is an area I'm very actively interested in, because we now have ways we can quantify plaque with the advancements of AI technologies, and we can identify high-risk plaque that is often more pronounced in people with autoimmune diseases. We can also, through the ability of radiotranscriptomics and LLM models, we can also look at coronary inflammation through these CT-based metrics. And I think that those types of technologies embedded in this are actually going to, hugely have our ability to screen and identify disease early and start to tailor treatments. I also just mentioned that atherosclerosis is something we frequently talk about, and it is of utmost importance. But we can't forget in autoimmunity the advancements of identifying all the other components of cardiovascular disease, such as heart failure. We know heart failure is increasingly common, increasing the role of heart failure, preserved ejection fraction. And I think a lot of the areas of innovation is the increasing role of cardiac MRI. This can really detect much more structure and function in terms of our patients of autoimmune diseases. And so that, those two modalities, I would say, are areas of importance for the future.
Yeah, I can't believe that I forgot to mention imaging. And Dr. Weber is the world's expert on cardiac imaging in these patients. I think in the future, we need to know how to use these. I think it's coming thanks to your work. We need to know, which patients, how often, which modality. They're expensive. I mean, other blood biomarkers are expensive, but the imaging biomarkers are also expensive. Also, insurance companies don't always like you to send patients on all of the tests.
Yeah.
So while exciting, there's work to be done, so it'll keep you in business for a while. Figuring it.
Well, we have a very engaged audience, which I love. So I'm going to throw out a couple more questions to you guys, particularly with autoimmune conditions where there are flares often associated with diet, and in particular gluten. Can you speak, or maybe other kind of triggers, Dr. Constibator, to how diet and sort of the role of kind of lifestyle factors play into management of disease and even in the diagnostic journey?
So diet is very important to patients. It's very important to managing disease. It's something that patients can control. There are increasing number of studies about diet in autoimmune disease. Definitely gluten is a trigger of celiac disease. We know that it's the cause of celiac disease. And many other people are sensitive to it. We also know that ultra processed food, which is junk food in general, is related to risk of many autoimmune diseases, including lupus, rheumatoid arthritis, and others, and probably exacerbates the disease. Lots of interest in the microbiome, and the role of fiber in decreasing inflammation that may start in the GI system in the gut. So I think that there are, healthy guidelines. Luckily, the healthy eating guidelines for prevention of cardiovascular disease also really align with what you can do for yourself to keep your autoimmune disease in check. You don't have to go crazy, but with ultra restrictive diets, I think. But following the healthy eating index, kind of making sure that there is a healthy amount of fruits and vegetables, of complex fibers rather than ultra refined white bread and white rice and potatoes, and getting protein from nuts and beans as well as animal sources. And those diets, it's very hard to do a nutrition study for an outcome by itself because of our disease, because we've all just mentioned that our disease wax and wane. And of course, that means that treatments are going to wax and wane, that steroids are going to wax and wane. It's hard to do a randomized controlled trial and keep somebody on a healthy diet versus an unhealthy diet for a year. So we don't have a lot of trial data, but we do have a lot of retrospective data, and patients also feel better when they are on healthier diets. But there's access there as well, problem, because healthier diets often are more expensive.
Right.
So access to fresh fruits and vegetables and fresh foods in general is not equal across the country. And that's another thing that we need to, I wish we could. In some places, I think people do, maybe nutritionists do, write prescriptions for fresh fruits and vegetables, but they're not often covered by insurance.
Yeah.
So we do send a lot of people to talk to the nutritionist about things that they can change in their diet to make them, feel better, etc. Things that they are not aware of. I think an alarming statistic is that now up to 60% of the calories per day in a U.S. adult comes from ultra processed food, junk food.
Yeah.
60% of the normal diet. And there are disparities there, and this is higher percentage in people with less than a high school education. We really have to combat that problem. Eating basically junk food, ultra processed food, chips, donuts, sodas, and I think that will help cardiovascular risk and autoimmune disease risk and mental health.
Yeah. I couldn't agree more. Just to kind of tag on just a real quick comment is that all the things she just mentioned are so true in terms of reducing cardiac risk, in terms of, I can't emphasize more. It's not just get them on, on a statin therapy. It's actually, the AHA's Lifate, right? It's actually, diet, nutrition, nutrition education, exercise, it's discussing all these about the importance of them. And I completely agree. We have to be innovative because of not only the lack of education, the lack of disparities in terms of the cost. I was just at the American College of Cardiology meeting, and there was one of the late breaker trials that even looked at this in terms of kind of a prescription in terms of actually giving people, things they can choose at the grocery store, and demonstrated how it lowered blood pressure. And we have so many examples I could cite off in cardiology in this area of just the importance of diet in terms of cardiovascular risk, and also many other risk factors such as hypertension and weight management and cardiometabolic syndrome. And so this is another area that I think is really ripe. And actually, just little things like Dr. Conspater mentioned is we try to direct them to the nutritionist, but I find that many times that especially we're lucky we are at top academic medical institutions. I'm at a phenomenal prevention program at UT Southwestern, but the majority of centers don't have access to specialized nutritionists, and where patients can really just benefit from some education on what they could be choosing when they go out and to those restaurants or to the grocery store.
Yeah, for sure. Completely shifting gears, but hopefully keeping you guys on your toes. Maybe for Dr. Weber first, speak a bit to Hashimoto's thyroiditis and cardiovascular disease, and how that interplay is. Any studies or research areas there that you could speak to?
Yeah, I don't have actually a lot I'm going to add to this. I may actually see if Dr. Conspater does. I will say though that it is one of the most common, right? If you look at common autoimmunity, it's often frequently up there as a very common autoimmune condition. It's not at least in terms of what the studies I know off the top of my head. It's been less well studied in terms of disease specific, as if we were to compare that for lupus. And I don't think of it as a similar risk than I do a patient with lupus and rheumatoid arthritis or psoriasis, for instance. But that being said, I don't want to discount it as well, because if you looked at the Lancet paper, it did show that people with Hashimoto's thyroiditis did have increased cardiac risk. So I think this really gets into one point that I would like to make by your question, is that what we certainly, I think, are still have so much more to uncover is actually the risk within these disease-specific autoimmunity, right? Take something like alopecia. There's something people may say, what is that? But it's a dermatologic condition where you have loss of your hair, and one could say that's associated with increased risk, but actually there's increasing studies that I've been reviewing in the dermatology literature that are coming out on that. So similar to Hashimoto's, I think that we really have to have better studies on disease organ specific. And these are often conditions like Hashimoto's that are not followed by a rheumatologist. And so this shows you the breadth of the topic that we're discussing today, because this really, when we think about single organ specific disease, then really this overlaps with all specialties in medicine, including, endocrinology, which would be seeing these patients.
True, yeah. I think for Hashimoto's, actually, it's so common that our endocrinologists won't even see it. It has to be managed by primary care physicians right now, who are probably not aware of the increased risk of cardiovascular disease. They know how to, prescribe thyroid replacement, which is usually the treatment. And Hashimoto's is caused by autoantibodies to the thyroid, and Graves as well. Graves is a condition of hyperthyroidism. Both are associated with increased cardiovascular risk. And Hashimoto's also leads to increased lipids, right? Hyperlipidemia and hypertension, metabolic syndrome, weight gain, if not treated. So it can have a lot of ramifications that way. And we see a lot of patients in our lupus program, patients with other autoimmune diseases. Hashimoto's often overlaps with other diseases. So in terms of the patients who have multiple autoimmune diseases, it's very common for my patients to have Hashimoto's as well. So that needs to be under control as a more traditional almost risk factor. If your thyroid is not working in the right range, it will contribute to cardiovascular risk.
Yeah.
Leads to my last question in our final minutes together. I really would love both of you to talk about sort of centers of excellence. So we held a summit earlier this year, and one of the big wishes is for more of these centers of excellence around, because of this interdisciplinary play, because of the desire to sort of treat multiple conditions that have confounding factors. Maybe start with Dr. Constibator, but I'd love you both to speak to, what are these integrated centers that we need to move forward to, both from a research perspective and from a care delivery and clinical model perspective? Sort of what is your continued vision there?
Yeah, I couldn't agree more. And we are very lucky here at the Mass General Brigham to have a very large lupus program, which is very multidisciplinary. So as I mentioned, we have specialists involved, and we have monthly meetings of these specialists from all different specialties, including psychiatry and neurology and cardiology, definitely kidney specialists and the dermatologists and the GYNs, because lupus is a systemic disease that affects multiple diseases, multiple organ systems. But so that we can share cases, we can share papers, we can do journal clubs, we can talk about what's new. We can support each other through getting grants and brainstorming ideas and doing studies. And I think that that's what makes it the best kind of quality of care, because we can communicate this way. I think even in single organ system diseases, it would be ideal to have a center of excellence that sees a lot of them from many years of study for many diseases. Centers that see more of the disease have more specialized care. So I think that we have a huge volume of lupus and rheumatoid arthritis here. It sounds like Brittany has a new cardio-dermatology. Dr. Weber has a new cardio-dermatology center at UT Southwestern, which is very exciting. Bring those together. But getting these off the ground is challenging, and it takes large centers. We have an access to care problem for all kinds of medical care in the country. So just getting in to see a primary care physician is often a challenge. And then getting into a specialized multidisciplinary center is extremely challenging.
Right.
But I think that a lot of the advances have come out of these centers. We can follow people. We can figure out how often they need to be followed with their cardiac, their coronary CT or their cardiac MRI. We can figure out things because we have a large volume of patients. We have a lot of people studying the same disease, and these are relatively rare diseases for a lot of the autoimmune diseases. So I'll leave it at that and see what else Dr. Weber has to contribute.
No, I couldn't agree more, and I love that. I love getting to talk about me and Dr. Conspirator's dreams, right? All these things that we we wish and dream about. But I think we autoimmune. So I first an autoimmune center of excellence. That we've talked a lot about how the heterogeneity of all these diseases and about how like right now we have a lot of disease specific centers of excellence, and even within cardiology, there are pericarditis centers of excellence, and I see a lot of these patients, and they'll come to me for looking for that expert care. But I think in terms of the broad notion of autoimmunity center of excellence, I love the idea, and I think what we have to the challenge for all of us is that we don't have this is not just like a brand, right? That we really define what a model like what is the operational model of something like an autoimmune center of excellence. And you've already heard us things that we all think, or Dr. Conspiner, I think are really important in terms of what you cannot deny among all these diseases is the need for multidisciplinary. So that just has to be, I think, at the forefront of any kind of model of a center of excellence. And then my dream in terms of these centers and models would be that you have coordinated, access to the different specialists by which you need to be seen. You could have standardized intake forms. Like standardized intake forms could facilitate research. It could facilitate increased access. I mean, I've even been thinking of small things like this in terms of the pericarditis piece I see is like, can I standardize a questionnaire that may help me get them to the biologics faster? And then that would also enable if one could define operating models like this of autoimmune centers that would really allow registries, which were really going to be the way we can answer all these questions we do, and also getting patients eligible for the clinical trials because the field of rheumatology, as we've already said, is going like this, and so getting people access to the current studies on the most novel treatments would be beneficial both for cardiology as well as the autoimmune disease itself.
Agreed. Well, thank you both for both of you today for making time for us. It was a great discussion, covered a lot of ground. For our audience, the recording will be available in about a week on our website. And I encourage you all to scan the QR code to follow future events that we have here at the Inflection Point webinar series. But thank you both to Dr. Constibator and Dr. Weber for today. Appreciate you.
Thank you so much for having us.
Yeah, thank you very much for the invitation. This is fun.
Yes.
Great
Good discussion.